Hello. It's truly an honor to be among you to speak about this very interesting topic. Thanks again for the invitation. Um, I will. This is my conflict of interest related to this presentation, and so let's start. So, do patients have to choose between ejaculation and miction? Well, ejaculatory dysfunction is the most common side effect related to surgical treatment of benign prostatic obstruction, as you know. It has been considered for decades as a tribute to pay in order to restore urinary comfort, or even sometimes as a surrogate marker to complete obstruction relief. More recently, a better understanding of ejaculation physiology has enabled the emergence of modified surgical techniques with the aim of preserving antegrade ejaculation. In addition, there are non-ablative techniques, meaning invasive techniques such as urolift, resume, and prostatic artery embolization that also have emerged, showing convincing results on ejaculatory function preservation. So, to better understand this question, we need to approach the problem from a different angle. What is the patient's wish and what importance does he give to preservation of his sexuality? We already know that patients have or would like to have a preserved sex life, even at a fairly advanced age. In this study, as you see on the screen, it was a survey over 12,000 patients aged between 50 and 80 years old. And what we see is that 83% of men declared still having sexual intercourses, and even 71% of them in the last 4 weeks, which was the most astonishing, was the age. Patients between 70 and 80 years old declared having 3 sexual intercourses per month. Whether it's true or not, well, it's what they declared, it still represents their aspirations. So urologists have to take that in account. Even elder patients might have a sexuality and might need to preserve it, even when treated. So, erectile dysfunction might have a substantial deleterious effect on quality of life. That we know it for sure. And it might have induced significantly increased level of anxiety and depression. That had been shown in several studies. When we have a look at a series where we asked patients what did they think about the sexual disorders after BPH treatment, a quite astonishing result is that after surgery, 74% of the patient said that they were disappointed, but still able to tolerate the sexual side effects, owing the improvement of their LUTs. But 8% were dissatisfied and even wanted to reverse the situation, even though they had LUTs relief. And more than 50% of the patients declared having a decreased orgasmic intensity because of the surgery. So you have to think about it. So what are the rates of ejaculation disorders for our BPH surgery? We already know it, but let's have a look at what we find in the literature. Well, whatever technique we use, TURP, green light, endoscopic enucleation, HoLEP, TULEP, green LEP, name it, whatever. It's about 70% of anejaculation. But there is still an exception that is easily forgotten, and that's TUIP. TUIP is quite good in ejaculation preservation, and we have to keep it in mind because it's a good explanation of what happens in the physiology of ejaculation. The only drawback of TUIP is the retreatment rate and the fact that the indication has to be carefully chosen, mostly based on prostate volume. So, if ejaculation is so important, is it discussed during our consultation? Well, you'd be quite astonished because not that much. In fact, when we ask urologists, we realize that in 70% of the cases, it is omitted, even when urologists are counseling patients about surgery. not just drugs, medication, also surgery. So what about publication? It's the same thing. Until recently, most of the studies about BPH surgery didn't use any ADAPT scores for ejaculation, especially the MSHQ. So clearly, modern BPH treatment has to evolve in order to address the patient's demands, especially on sexuality. So what patients do really want? That's an important question. So in this survey, what men said that they preferred conservative and less risky treatments, pharmacological treatment with a low risk of erectile dysfunction, and treatment that reduce the risk of acute urinary retention. What we see is that patients are quite concerned about their sexuality, especially when they undergo surgery. So the other question that we have to ask ourselves is how ejaculation works, I mean, physiologically. Have a look at this anatomical drawing. Well, you see all the ejaculatory ducts, they're opening on the verumentanum. You see that it's a quite complex structure, and that ejaculation is not all, might be a more complex phenomenon as what we might know. These images, we know them by heart. It's everyday practice. You see all these small ejaculatory ducts. So when you do a resection of a prostate, you never see a wide open ejaculatory ducts. You didn't open it. It's not a retrograde ejaculation. It's an anejaculation because you closed the ejaculatory duct because of the energy you use to resect or destroy the adenoma. So this is not true. And the other thing is that ejaculatory disorders are not due to an absence of closure of a bladder neck. It's something else. So in order to preserve ejaculation, we have to really respect the area around the verumentanum. So what happens? This is an ultrasound view of what happens during ejaculation. What we observed is that the verumentanum will show a slight caudal shift, momentarily making contact with the opposite urethral wall. It will then rupture the lumen, and then the sperm is emitted. And what we also know is that there will be a high pressure area, ejaculatory area, that will be surrounding the verumentanum, and that the bladder neck has nothing to do with it. And that's why when you perform TUIP, there is no consequence on the ejaculatory function. So how do we go from anatomy and physiology towards surgery? Well, we know several things about the mini-invasive techniques. There are lots of them. There is embolization, resume, urolift, iTind. Aqua beam is not a mini-invasive treatment. It's more like an alternative ablative technique. But we'll talk about it because it's one of the newest techniques that we read about nowadays. So let's start with prostatic artery embolization. It consists in unilateral or bilateral embolization of prostatic arteries by polyvinyl alcohol particles performed under local anesthesia by femoral approach. There is solid RCT comparing embolization with TURP, which is the gold standard. And what we see is that prostatic artery embolization is less effective than TURP at improving symptoms and flow rate. The procedural time is also longer when compared to TURP, but there is no blood loss, and catheterization and hospitalization time is in favor of embolization of a prostate. But we also see that there is 21% of retreatment in the two following years after embolization, and that there is at least 50% of ejaculatory disorders described in embolization of a prostate. Nevertheless, what we can advise is that this kind of treatment must be done by a multidisciplinary team with a urologist and a highly trained radiologist. with a very specific expertise. And what we also know through the literature is that a larger prostate might have a higher chance to benefit from this treatment. So it's better for larger prostates. There's also no comparison for the moment with other non-invasive techniques, just with TURP. So it's hard to determine its position among the other mini-invasive techniques. There is another treatment, the Resume. The Resume system, as you can see on the video, is a water vapor delivery device that is inserted into the adenoma under direct visualization using a needle. It's under local anesthesia. The water vapor is delivered inside the adenoma on several punctions, and the number of punctions is depending on the prostate volume. This vapor will induce a necrosis of the adenoma, which will disobstruct the prostate. So what is the evidence? Well, one of the most important results is that there is no de novo ejaculatory or erectile dysfunction reported for this technique. Well, it's a very nice result. What we also see is that the 4 years outcomes prospective are quite good. It's significantly better than a sham procedure, but it has never been compared to the gold standard, which is TURP. There is currently an ongoing study versus dutasteride, but not against TURP, which is a shame. Another mini-invasive treatment is the UroLift. This is, at the moment, the most solid mini-invasive procedure considering available data. So it's a non-ablative technique, endoscopic, and you spread the lobes using 2 to 6 permanent implants, which are anchored on the capsule and the urethral lumen, which will create a channel in which the urine will pass more easily. This technique is better for small prostates between 20 to 70 milliliters, and you have to avoid prostate with median lobes because it's very difficult to treat the median lobes with this kind of device. It's an outpatient consultation modality treatment under local anesthesia, and there is no need for urinary catheter after treatment. This UroLift improves IPSS and Qmax and quality of life. However, these improvements are inferior to TURP at 2 years. So this is important. The results are good, but it's inferior to TURP. There's also another question about the retreatment at 2 years. Almost 14% of the patients needed a retreatment after 2 years, and only 6% with a TURP. So patients have to be informed of this specificity. But the very good result is about ejaculation preservation. There is no sexual dysfunction after this treatment. That even it's less than TURP in terms of correction of the LUTs, it's still good. So it's a very good option for men interested in preserving ejaculatory function, but with prostate underneath 70 milliliters with no middle lobes. There's another technique, which is the iTind, which is a nitinol device composed of 3 elongated struts that will be anchored inside the prostate. You put it under direct visualization by endoscopy, and as you see the device spreading, it will induce a compression on the tissue. This compression will lead to ischemic necrosis, resulting in 3 cuts, 3 incision of the bladder neck and the prostate. Then 5 days after, the device is removed in an outpatient setting by standard ureteroscopy. in an RCT, the results were significant versus sham procedures with good symptom relief. But still, it hasn't been compared to any reference technique. There's no published data, but randomized controlled trials are still ongoing, and we wait for the results. Then finally, there's this other innovation, which is the aquablation. And I repeat, this is clearly not mini-invasive, it's ablative. But I will mention it because it's a robotic-guided ablative technique that combines image-guided high-pressure saline jet and which is heat-free, and as you see, it destroys the tissue this way. Which is interesting is that you can preserve the ejaculation because you clearly define what is the area to treat, and if you don't destroy the virimontanum, of course, you will keep the ejaculation. So it's mentioned especially because of its precision in order to preserve the critical zones. What is the available data? Well, in midterm follow-up, aquablation provides non-inferior functional outcomes when compared to TUP, and for prostate volumes between 30 and 80 milliliters. And we need, of course, longer follow-up in order to conclude. If we put all these aside, there's another way that doesn't require any new equipment. And that's partial resection of a prostate, which is a very promising approach because it doesn't require any special equipment. It uses only common surgical devices such as TURP, vaporization, enucleation, whatever you use in your daily practice. And recently, we had a consensus between experts that took place, and we defined how was the better way to do this kind of surgery. So we defined the structures that must be preserved. So the anatomical landmarks to be preserved are located around the virimontanum and along the posterior part of the prostatic urethra. These structures must be preserved up to 2 centimeters from the virimontanum. In order to be efficient, the urethral mucosa has to be untouched in all the areas that you intend to preserve, and you necessarily have to reach the enucleation plane in the rest of the prostate where you intended to make a perfect resection. According to the unfortunately low level of evidence in the current data, this technique seems fairly promising with a good success rate of ejaculation preservation, around 70% of success rate of the ejaculation preservation. However, we lack data for long-term outcomes, especially for reintervention rates. The longest follow-up we have is 60 months, and the reintervention rate was about 30%. But there are ongoing RCTs that are assessing this kind of modified surgical treatment. So this is an example. It's a very short video. We performed a TURP. Of course, you won't see, this is the prostate, and you'll see the final result of the surgery. There you go. So now the surgery is finished. And as you see, there is the area of the virimontanum that is untouched and keeping some adenoma all around it in order to make the ejaculation possible. So if you make your resection, whatever you're using a technique, it could be vaporization, could be enucleation, could be resection, bipolar, monopolar, whatever, if you keep these anatomical structures and you make a very good disobstruction above, well, we'll have very nice result that are the same that are described in the literature. So we will move to the conclusion about the non-ablative therapies. It is very important to select patients with moderate prostate volumes between 30 to 80 milliliters because of a lack of data for large prostates. We do not know what really happens for these patients. So keep it small. We also lack data regarding the midterm reintervention risks of all these techniques. So it is mandatory to inform patients of the theoretical risk of reintervention. It is also reasonable to propose these therapies to patients with moderate discomfort because we expect a less improvement of the IPSS, around 10 points, and a moderate expected improvement of the Qmax, around 5 milliliters per second. Therefore, patients with very, very important symptoms or obstruction should avoid this kind of techniques that we know that are inferior to the gold standard, the TURP and the OLEP. So my take-home messages are: advise patients about sexuality and BPH treatment. That has to be mandatory. Include sexuality evaluation in your BPH assessment and follow-up. This is very important. Ask patients what are their priorities regarding the treatment strategies. Include several treatments options for your personalized management in your daily practice. It's important to have several solutions in order to maintain ejaculation when the patients want it. And be aware of a major uncertainty about all these techniques is that we don't know what happens in midterm retreatment risk. So you have to inform patients. It's very, very important. And if I have to say one word, is personalized management for BPH patients. Thank you. Thank you for your attention.